recording live from somewhere. This is Zach Couples with episode number 125 of the Movement Debrief. And today, folks, first things first, man, you're learning from the worst, because we're going to talk about protecting your neck. Yes, all things neck range of motion, every type of Wu-Tang or hip-hop pun that I can come up with. No disrespect, keep your neck in check. Because your boy, Big Z, abnormally large Z, has got a bunch of questions that have been asked by the people. They will be answered for the people by this people right here. Fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from Jason. Here's what Jason asks. Possible topic for another debrief. You've talked at length about the foot, the pelvis, the ribcage, the scapula, and spine. But how about talking about the head and neck? I understand the relative motions are supposed to exist within the cranium, but I'll be damned if I understand them. Love your work. Perfect. Let's talk neck. Basic respiratory mechanics of the neck. You didn't think I had a neck thing, but I do. It's only upper cervical though, unfortunately. When you take a breath of air in, the OA, bottom part of your cranium, is going to extend or tip backwards, OA extension. That's going to be accompanied with lower cervical flexion. So that's going to see a slight reduction in the normal lordotic curve that you should have within the cervical spine. That's going to allow us to have maximal airway diameter or dimensions so you can get as much air in as possible. With exhalation, that should reverse. The cervical spine, or the upper part of the cervical spine, the OA should flex. You're going to see some lower cervical extension or restoration of the curve in the cervical spine. If I take that to the cranium, and we're talking about the sphenoid and all that stuff, generally there's an alternating directional movement of the OA and the sphenoid. Now, of course, there's not a whole lot of movement going on within the cranial bones, but there probably is some, or at least can we agree that the muscles are probably acting in some way, shape, or form, even though they're not pulling on the specific bones or creating a bunch of movement within the bones. If I have OA extension, cranium tipping back, the sphenoid, the top part of this bone, is going to tip forward. And this will actually be useful when we talk a little bit about facial structure, but the sphenoid is going to flex forward. And then that reverses when I drive OA flexion. When I flex the OA, the sphenoid is going to tip up. Those are some of the basic respiratory mechanics when we're discussing what's going on at the neck. Some other useful things to think about. When I turn my head, a bulk of the rotation, about 45 degrees, is going to happen in the upper cervical region, typically about 45 degrees. The rest, C3, 7, is what makes up the rest of the rotation, which is also about 45 degrees. Also, too, when you do turn your head, there is motion all the way down to approximately T4 in the thoracic spine, thus showing the intimate relationship between the cervical spine, the cranium, and the thoracic spine, because all of these areas move together as one lovely, sexy, outstanding, cohesive unit. And those would be some of the big things that go into normal cervical spine biomechanics. And of course, Jason, don't worry, we're going to get into abnormal because there were a lot of questions today about the neck. The next question comes from Isaac. Here's what Isaac has to say. What's the relationship between the neck, thorax, and scapula? How do I program with issues here? For example, forward head posture, medial scapular pain. What's going on with that? Now we're going to dive into compensation nation. Let's talk first about the relationship between the neck and the thorax. As we mentioned, literally like 37 seconds ago. How cool would it be if you're tuning in on YouTube and you turn back and it was like actually 37 seconds that I mentioned it? Anyways, 37 seconds ago, I mentioned that when I turn my head one direction or the other, you get rotation through the thorax to about T4. Now, let's think what's crack-a-lackin' at the thorax when I rotate to the left or to the right. When I rotate my neck to the left, you're going to see the spinous processes, the pointy things on the back of your spine. They're going to go away from the direction that you're rotating. So if I rotate my neck to the left, the spinous processes are going to move to the right. Now let's think about this from a thorax expansion standpoint. If I take a breath of air in and I do it on one side, you're going to see two things. You're going to see the medial border of the scapula move away from the middle part of the thorax, and you should also see the spinous process rotate away. Therefore, if I turn my head to the left, that's going to bias and improve posterior expansion on the left because the spinous process is going to rotate to the right. So many times you'll see, and you've seen this maybe in a couple drills that I've been doing, some of these that I got from Bill Hartman, check him out. I'll link him in the show notes, which will be found on zachcouples.com/neck. But if you rotate ipsilaterally, and it's done during inhalation, that's a lot of times what you'll see. So like if I'll also link an arm bar that I'm doing in the show notes. But when I inhale, I ER the arm and I turn my head to the left. That's to maximize expansion posteriorly in the upper part of the thorax, in particular T2 to T4. So a lot of times, if you have someone who's restricted in those segments, how would you know? You'll see restrictions in horizontal abduction. You'll see a loss of shoulder flexion. Likely you'll see a loss of rotation ipsilaterally or towards that side. But you can drive expansion in that region by simply creating a head turn, ensuring, of course, folks, that you got a stack. So making sure you can keep the thoracic diaphragm, pelvic diaphragm atop one another. That's always going to supersede things. Because if you can't stack, don't talk to Zach, because you're not going to be able to create effective rotation to drive air where you want it to go. You got to get the bottom piston in business before you start working upstairs. So if you got someone, let's say, who's got medial scapular pain, and without getting into the biopsychosocial, maybe it's because you got something wild and crazy going on in life. Save the trauma for your mama. We're talking biomechanics today. But if I have a medial scapular issue, if I have concentric bias back there, that could be creating, or that could be abnormally influencing circulation. That might lead to ischemia within the tissues locally. And if the stars align perfectly within your complex system and there's enough nociceptive input to say, hey, we got a problem here, you could lead to some medial scapular pain. So the solution would be to create expansion in there. And the way you could do that is by driving external rotation of the humerus, which is going to, but not too far, but you drive some ER of the humerus, that would relatively IR the scapula. And then if you turn your head to the left, woo, you're doing something fierce. You can also bias the IR of the scap even further by reaching low, like a 0 to 60, or reaching high, 120 to 180, assuming you can stack. If you want to learn more about specific reaching, I have a great debrief that I'll link in the show notes called Reaching Theory and Practice. Other things that Isaac talked about. So we talked about medial scapular pain. What the heck's going on with forward head posture? How does that happen? Because it happens, right? Well, if we think about the mechanics that I had mentioned before, normal respiratory mechanics of the neck, you got OA extension, head's tipping backwards, and lower cervical flexion. What would happen at the thorax that would contribute to that would be this kind of forward position of my thorax, which would be, from a biomechanical standpoint at the rib cage, a down pump handle. So if I exhale or I concentrically bias the front side of my body, that pulls the lower cervical spine into flexion. Well, I got to look up every once in a while. You get OA extension. Test findings that would implicate you got that going on, aside from visual presentation, is you'd have a loss of shoulder extension, adduction, and internal rotation based measures. If you see that, you probably got a down pump handle. That could be contributing to the forward head posture. What would you do in that case? Well, I'm glad you asked. What you would do, assuming you have the stack, just like let's assume that from here on out, is you would need to drive air into the front side of the body in order to upright the thorax, or at least improve the movement options within the thorax. And the hope would be that that positively influences the positioning of your neck. Ways you would reach, if I'm someone who's a narrow infrasternal angle, if you're just tuning into this and you don't know what the ISA is, your boy got you in the show notes, don't worry about it. A narrow infrasternal angle is going to do a forward-based reach to drive air into the front. The reaching debrief will also talk about that. If I'm more of a wide infrasternal angle presentation, you want to reach at about 120 and beyond. To summarize your great question, Isaac, if I'm rotating the neck, that's going to be associated with rotation of the thorax or the thoracic spine all the way down to about T4. So if you turn one way, that's going to expand posteriorly on that side. You want to, if you have someone who's got compression on that side or a reduction of motion, they can't get expansion posteriorly, which would be signified by external rotation restrictions. You could drive rotation towards that side to facilitate expansion in that region. If you got forward head posture, that's typically going to be seen with a down pump handle, loss of extension, adduction, internal rotation. If you got a down pump handle, what you need to do is create activities that would drive expansion into the front side of the body. And of course, I got you. I will link some of my moves that I like for that as well. For narrows, it's going to be forward reaching. For wides, it'll be 120 and beyond. Awesome question, Isaac. The next question also comes from Isaac. He just went like with questions, which I appreciate because I love his questions. This is about neck popping. Zach, what's the thought process for dealing with necks that crack and pop when you rotate them? Very simple. I'm not super concerned about neck popping and cracking. When we move, we have all of these tissues within our body sliding and gliding along one another. It's all encapsulated in fluid. It's not uncommon for, as these tissues move, for them to make noise. And oftentimes that can be a cavitation in the joint. Now, the research is kind of like meh when it comes to what exactly is going on, especially in the extremities, but in the neck it's a little bit better. Generally, if you're hearing popping and cracking, what's going on is there's a gas bubble forming within the synovium. Pretty normal. And so the bubble formation is the pop that you hear. A lot of times that will happen if you haven't been moving at a specific area for an extended period of time and all of a sudden you go into a position. Sometimes that creates the cavitation that you hear. It's not, unless there was some type of traumatic event that was consistently associated with pain. The pops, cracks, all of that stuff is generally not something to worry about. Unless you're a secret agent, because then you can't sneak up on anybody. But otherwise, it's not really something to be concerned about. I would just encourage these folks who do get a lot of popping and cracking when they move to not be alarmed. It's a normal thing to happen when the tissues are moving or when we move. It's okay. Chances are you just need to keep moving as best you can, explore the ranges of motion that you might not be getting into, and you'll probably be in business. So I don't deal with crack. I'm not messing with it. Don't sweat it. Great question. The next question comes from Chris. Here's what Chris asks. Thank you for your work. How can I self-assess my hyoid? Great question. One thing I neglected to mention is when we're talking about neck positioning, range of motion. You know, everyone gets all hot and bothered about the deep neck flexors. You know, because it's like, oh, yeah, I gotta go chin tuck myself in order for my neck to feel better. Stop. We went way too deep. We're in too deep, and not in the cool way like that Phil Collins song that I like. Instead, there's a bunch of other muscles in front of that we should be concerning ourselves with. Namely, you got like all of these muscles that attach to your hyoid bone. And the hyoid positioning and orientation can be influenced by what's going on at your temporomandibular joint and subsequently your head. So in some cases, you can have an alteration in the concentric or eccentric bias of the front neck muscles that attach to the hyoid, the suprahyoid muscles and the infrahyoid muscles. Let's dive into that. If I'm someone who's stuck in more of a forward head posture, you got lower cervical flexion, you got OA extension. Oftentimes that's associated with more of a open mouth position as well. And the reason why that is goes back to actually the normal respiratory mechanics. Remember, if you were tuning in earlier and you were paying attention, hopefully you were. If not, hit rewind when this is on YouTube. OA extension is associated with sphenoid flexion. Here's the cool thing about this. If the sphenoid is flexed, you actually get like an anterior tilt of the cranium. You don't believe me? Look at someone, aka your boy, who's got a retrognathic or a retruded mandible. If you actually look at the X-ray imaging or you get some CT scans and you see a longer lower part of the face, we would call this vertical facial growth. What actually happens is you get this forward or anterior tilting and rotation of the face bones themselves, which is really cool. Well, it's not really cool because there's some airway issues, boy, but neither here nor there. But you actually get like a forward rotation of the face. And as that happens, you're going to get an opening of the mouth as well. When the mouth is open, the hyoid depresses downward. If I simplify the hyoid musculature into two different types, suprahyoid, supra being above the hyoid, and infrahyoid, those muscles that are below the hyoid, the infrahyoid muscles are going to be more concentrically biased because it's pulled down, and the hyoid muscles on the top, the suprahyoid, are going to be more eccentrically biased. If I have a situation where I'm more of a military head, typically associated with wide infrasternal angle presentations, but I got OA flexion, lower cervical extension, what's going to happen there is you got the sphenoid being in more extension, and they have more of just a retracted head posture. In that case, the hyoid is more elevated. So you have concentric bias in suprahyoid musculature, and then you have an eccentric bias in the infrahyoid musculature. Now, you're probably wondering, if you've been following me for a minute and a half, well, Zach, that's all well and good, but I've noticed that you've spoken a lot about people having secondary or superficial compensations. Can this happen at the hyoid? Why, yes, it can. You can have a situation where you are concentrically biased, both up top and down low, from the hyoid standpoint. And how do I know what my hyoid is? First off, look at your posture. Oftentimes that will give you a sense of what's going on from the OA positioning or the hyoid positioning. So if I got more of a forward head, chances are I'm going to have more of a depressed hyoid. If I have a retracted head, chances are there's going to be an elevated hyoid. If you got some limitations in cervical range of motion everywhere, you probably are double concentric. But with the hyoid position test, which I got from Bill, what you would do is you would tip your head back, and then once you hit your end range, open your mouth and see what happens. Generally, this works better if someone is restricted in OA extension because you're going to see a couple things. Well, first off, if I have the double concentric action, you'll see range of motion improve because you've altered the orientation of the hyoid. stuff. So let's go forward head posture first. Forward head posture. Infrahyoid muscles are concentric. If I tip my head back and I open my mouth to get those puppies to relax, what you'll actually see is a eccentric orientation of those things. The lower part of the cervical spine should be the predominant location of movement. If I'm the reverse of that, the hyoid's elevated, and I can't go any further, open the mouth, that gets that stuff to relax, you'll see the upper part of the cervical spine start to move more. So like mid-cervical on up. Which, again, it's like you have to have a little bit of an eye for these things. Generally, what I would say is if you open the mouth and you notice there's a positive change, I would use that in concert with the side profile posture to let you know what the position of your hyoid is. And in my mind, the hyoid position test just lets you know if there's dynamics or not. You know, if you got full range of motion and you're not getting much of a head dip when you open your mouth, you probably, and you don't have a loss of cervical motion, you're probably okay. But that's what I would use to assess the hyoid. Now, the next question then would be, what you gonna do about it? So if I'm someone with a forward head, myofunctional therapy-based stuff is gonna be really useful. Stay tuned, but there's also a whole course review that I did on myofunctional therapy that I would definitely check out. If I'm someone who's got more the retracted head position, you're gonna do things to drive OA extension. I just oftentimes will cue, hey, undouble chin yourself, and that works really well. You just wanna make sure that they don't tip their head back. So anything that drives OA extension is very useful. Other things you can do to improve OA or hyoid dynamics, any type of inversion activities are gonna be good because that will allow the hyoid to move. And you can also do some swallowing stuff to improve the hyoid dynamics as well. Those would be the things that I would consider. We'll dive a little bit more into it when we talk about tongue posture today. To summarize, your great question, Chris, hyoid movement matters. If I have a forward head, the hyoid is depressed. If I have a retracted head, the hyoid is more elevated. You can be concentric both in supra and infrahyoid musculature. I would look at side profile cervical posture, look at neck range of motion, and then the hyoid position test is really useful for assessing if you have dynamics there or not, although you gotta have a little bit of an eye to know what you're looking at. If you tip your head back, open your mouth, and it goes further, you probably got some issues there. If I'm forward head, I'm not gonna do chin tucks, but myofunctional works really well at improving that. We'll talk about it. If I'm more of a retracted head, you need to drive OA extension. If you're concentric, if you're double concentric, I would probably do both. And if you do those things, you're probably gonna get some positive changes in your hyoid gains. You're gonna be in business. Great question. The next question comes from Ali. Here's what Ali asks. How do you inhibit front neck muscles which are in an overactive state leading to a forward head posture, especially the SCM and scalene, maybe on the right side? Perfect question. We talked a little bit about this with the last question, but let's dive a little bit deeper today. First thing, if you got a forward head posture, make sure you stacked and you've addressed upper thorax mobility first. More often than not, that will take care of things. So if your person has extension, adduction, internal rotation restrictions in the shoulder, and you're not doing the pump handle stuff that I talked about earlier, forget about it before you go to the neck. So that's piece one. Piece two, what if I still got this forward head thing? Then we might go into some myofunctional stuff to improve upon that. If I have an extended OA, flexed sphenobasilar joint or sphenoid, anteriorly tilted face, mouth drops low, dropped hyoid, you need to do things that elevate the hyoid first. Upside down swallowing is a great fix, but I got stuff that's even better. You also want to retrain tongue posture. So let's talk about what the tongue is doing in this state. So if I'm forward head, jaw dropped. The tongue sits on the floor of the mouth and slightly back. This can have negative implications on the upper airway because if the tongue's sitting back, it's going to reduce the airway space, so you're not going to get as much air in. That's one reason why you would mouth breathe in this case, is because you can take a lot more air in when your mouth's open as opposed to through your nose, especially if your tongue sits low and it wobbles to and fro. Doing things that restore tongue positioning can be quite useful. If the tongue in this case sits down and back, I want to bring the tongue forward and up. Simply focusing on that posture by putting the tip of your tongue on the spot. If you say the letter N, where the tip of your tongue hits, that's the spot, that's where the tip should rest, and then you want to get the rest of your tongue up to the roof of your mouth. Simply practicing that and working on opening and closing can be a useful way to work on tongue range of motion so you can get into that position. That would be one thing that's very simple, that's extremely useful. Now, if you have some restrictions in there, I would strongly encourage checking out the myofunctional post because that will go into a little bit more detail in regards to that. Other things you might consider based on this is doing swallows in that position. When you perform a swallow, your hyoid is going to elevate. A great move that I like is called a smile swallow. I'll link the full thing in the show notes, but you can watch it here. So what you're going to do with this is you're going to grab your Topo Chico. You're going to take a little swig of water. Keep the water in your mouth, and you want to trap the water in the tongue posture that we talked about. So tip on the spot, upper part of the tongue up on the roof of the mouth. And what you'll do is you will get the water there, smile with your teeth contacting, and without having any movement of the facial muscles, you're going to swallow. And if you do that right without any compensations, no like neck movements or, duck face that you've been doing on your Instagram selfie every day, you're going to get some dynamical actions of the hyoid which can improve the range of motion available. It will look like this. Take your Topo Chico. Ready? Try it with me, folks. Only if you have Topo Chico, though. That's it. What you will see people do is this. They'll make this weird face thing, and that's because they're trying to use superficial compensatory muscles to elicit the changes that you want or to have the dynamics. You ain't got that. Another thing you'll see, I see this a lot when I coach this move. Watch the side view. What did I do there? Well, what happened was I couldn't keep my tongue in the position that I needed, and I couldn't breathe while I swallow. You don't want to dive, so you're going to try to breathe. And when I jut my head forward, that causes my tongue to drop down and thrust forward, so I can make room in the upper airway and the throat to take the water in and not suffocate and die. So working on your swallowing technique can be really useful to improve the dynamics of someone who maybe has a forward head posture. Now, Ali also talked about improving dynamics on SCM and scalene. I also think the cervical rotation stuff that we talked about before is useful. So if I'm limited in cervical rotation to the left, you need to do things that expand the posterior thorax on the left-hand side, because in order for me to turn left, I have to have my spinous processes move to the right. That would be the big thing to consider when we're talking about cervical rotation. So to summarize your great question, Ali, if you want to get your neck to chill, fix the thorax first, make sure you have dynamics there. You want to focus on tongue posture, making sure the tongue can go up to the roof of the mouth, stretch it out, move the jaw without losing range of motion there. And then work on your swallowing to improve the dynamics of the hyoid. Make sure you can swallow without any compensations present. If you need to restore rotation, whatever side you're rotating towards, you need to be able to expand the posterior thorax, drive external rotation of the humerus, drive rotation of the thorax or of the cervical spine, and if you do those things, no one's going to mess with you. Great question. The next question comes from Isaac again. Here's what Isaac asks. I've seen your tongue exercises on the YouTube channel. When do you use those and how do you think about those? But here's the question that I really wanted to answer. Does this relate to palate shape and cranial positioning? Yes, it does. So for the person who has the forward head, anteriorly tilted cranium, or anteriorly tilted face, that person is generally going to have a more elevated or a higher palate. And I want you to think about this, okay? If your mind has been blown already, this is really going to blow your mind. So let's talk about who has a forward head posture. Generally. Not always, but generally. Generally, that's going to be associated with a narrow infrasternal angle presentation. Here's why. If I have a narrow infrasternal angle, think about what happens to their pelvis, right? The diaphragm descends like gangbusters. It means the guts move down. Sacrum's going to be relatively counternutated. When you got that, you don't want to fall backwards, so you're going to concentric stuff on the front side, boom, which is what pulls you into that forward head posture, because if everything's concentric on the front, the head's going to go forward. We've talked about in debriefs past, a ghost of debrief past perhaps. Narrow infrasternal angle is associated with a narrow infrapubic angle. What would be, right? Because if I have a narrow IPA, my favorite kind of drink, that's associated with sacral counternutation. What would be the equivalent of this in the face? It would be a narrow palate. So if I have a high palate, that's because the teeth are coming in closer together, which would be, OMG, a narrowing of your face or of your teeth. So as I squish the teeth closer together, the palate gets higher. And so it is the same pattern seen over and over and over again. So yes, it is associated with the infrasternal angle presentations that we talked about, and it does influence cranial positioning. And if I have a tongue that sits low and I have increased in vertical facial dimensions, which is what's associated with the anteriorly tilted face, you will see a higher palate presentation. So then the fix would be to do things to create expansion of the palate. Everything that we've talked about can be useful in that regard. Also working on tension of the lateral muscles of the tongue or the lateral positioning of the tongue. So doing things like a skinny tongue where you're poking the tongue out, or the pointy tongue, that can be really useful. But I also like when you get the palatal tongue posture where the tongue is sitting forward and up. If you can push into the sides of the teeth, that can facilitate the musculature in a manner that creates some widening of the palate. Now, I haven't had any specific clients where I've seen some changes in the lateral dimensions of the palate, but I've had a colleague who has, my buddy Joe Cicinelli. He's like the man with this stuff. Definitely check him out if you can find him. Good luck. He works in San Fran though. He's had some people have some millimeter changes in palate width, which is really freaking cool. I've had a person online who's measured similarly and has had some changes. It's not dramatic, but it just goes to show you the power of this stuff, that it can influence the shape and structure of stuff in your face. We can change our bony adaptations and things like that elsewhere. I don't see why the same thing can't happen in the cranium. So that's pretty cool. But the long-term fix, most likely if you wanted to get some dramatic changes, would be to work with a dentist or someone who can influence the dimensions of your palate. That's a topic for a completely different debrief and probably an interview with someone who I trust. To summarize Isaac's great question, does this stuff relate to palate shape? Yes. If you have a high palate, that's generally going to be associated with a forward head posture and an anteriorly tilted cranium, and because the tongue sits low. If you can get the tongue forward and up and pushed into the sides of the mouth, that could potentially create some room to expand the palate laterally. Not wild and crazy, let's not get nuts, but it can lead to some changes in motion. But if you do have a really structurally narrow palate, you might need some stuff done to improve the size of that. All right, on IG, Papa, nice to see you. Nice to see you too. Asked, well, how would a wide infrasternal angle get a forward head posture? Great question. Normally, a wide ISA would have more of the retracted military head posture. So how in the heck would they get a forward head? Well, I'm glad you asked. The way that a wide ISA would get a forward head is if they had a secondary concentric bias of stuff on the front side of their body. So somehow the pump handle went down and that brought their head forward. In a past debrief, I talk about secondary compensations. I'll link it in the show notes, but I would definitely check that out. But that's how it would happen. V. Chang asks, in terms of unilateral neck pain in a headstand, what could be causing that? Well, pain is going to be more multifactorial. I think I got to just put that into play because we don't know, right? There's a lot of influences in terms of why pain would happen. But if you have unilateral neck issues from a biomechanical perspective, realize that we are asymmetrical creatures. There could be some type of rotational issue going on. Perhaps you have a restriction in upper thorax expansion. But if I am in more of like this type of position where I'm resting my head, or I've got my hands clasped on my head and I'm pushing up through my arms, what would happen in that case is you are going to get some posterior concentric bias in the upper thorax, because when you're at that amount of shoulder flexion, namely about like 110, 120, the scaps are going to be more externally rotated, so you might have some restrictions there, and that could be biased one side to the other. Perhaps in that case you're getting some wonky rotation. So for example, let's say I can't get as much expansion on the left. That might actually rotate the cervical spine to the right. Maybe that abnormally loads some tissues there and you got some issues in your tissues. So the solution, try the stuff that I'm going to link in the debrief show notes. Good question. The next question comes from Wing. Here's what Wing asks. What type of assessment would you do to see if the patient can benefit from neck rotation and or jaw range of motion, or would the infrasternal angle be put into consideration? And what type of stuff would you do? Would you do like cervical protrusion or things like that? Cool, great question. So let's talk a little bit about the dynamics of head rotation and how it relates to the jaw. If I turn my head one direction, and this has to do with the movement of the cranial bones, the relative movement, I know it's not much, but the jaw is going to go the opposite way. So if I'm rotating to the left, I'm going to get some jaw movement to the right. Go ahead, try it. If you laterally deviate your jaw to the right, watch the position of your head. All right, my head, if I haven't moved it, is going left in relation to my jaw. So you have opposing actions happening at the TMJ versus the cervical spine. Am I going to do neck stuff or am I going to do jaw stuff in that case? Order of operations for me at this stage in the game is to make sure you address all the lower thorax and upper thorax and basically neck down stuff first. Because remember, the thoracic spine rotates all the way down to about T4 when I turn my head. So if that doesn't move, you got problems. You need the base first before you start going upstairs. Think of it like building a skyscraper. If you're building a skyscraper, you got to lay the foundation first before you start throwing too many stories on there. Right? If you're putting a story on there and the foundation's shoddy, chances are things are going to tip over, problems will ensue. So make sure you got all of the lower stuff first. Especially because I found in my experience, if I've gone to neck stuff up right away, or I've even gone into some rabbit holes that I shouldn't have went into. It's costly. Patient buy-in is significantly harder, and if you don't have the basic components there, generally the results aren't as great. So make sure you have that stuff first. Please, I implore you, get that first. Let's say you have it, which you probably don't. Practice it. Do you even stack? The answer is probably no. But if you have that, then I would go into a lot of the stuff that we've talked about. Adjusting OA positioning if needed, making sure the myofunctional stuff is there. So can they get into the tongue postures you need? Do they have adequate tongue range of motion? Check the myofunctional post. Can they swallow? Things like that are extremely important when we're talking about neck positioning. And guess what? A lot of times that will positively influence the movement dynamics that you have available or don't have available at the temporomandibular joint. A lot of times what I see from my peeps is they'll have an excessive amount of opening and then they won't be able to do the same amount of opening with the tongue tip on the roof of the mouth or the whole tongue on the roof of the mouth. Take care of that first, because that can favorably change the positioning and the dynamics of the temporomandibular joint. Offload structures there and life should be good. Let's say that you've done all that and maybe you still can't rotate the neck. Then, and most of the time only then, unless I have someone who specifically I'm seeing for some TMJ stuff and they need that so they have buy-in, then I would go after some TMJ stuff. So if you need to rotate to the left and you're restricted there, I would consider doing things where you're doing mandibular protrusion with the tongue postures that you've been working on. Push the opposite way. You can do some resistance there. You can combine it with other moves. You can get wild and as crazy as you want, but I like simplicity. So move the jaw forward with the tongue on the roof of the mouth, push it to the right. That's going to drive rotation in the opposite direction. And if you do those things, you ought to be in business. And that would be the order that I would operate with. Go proximal as can be, and then the distal will be the next thing to go. So ventral cavity, cervical spine, myofunctional, move your jaw. That's how I would do things. Dan, my dear friend Dan, asks, how would you differentiate between using arm bars versus inversion to get expansion in the upper body? Which is important because, as we talked about, with cervical rotation, I need expansion in the upper thorax to rotate effectively. So when is an arm bar useful? When is inversion useful? Inversion is generally going to be easier to get the expansion because if I invert someone, I tip them completely upside down, the lungs will fill from the top down as opposed to bottom up, thus making it a lot easier to get expansion in the upper segments. So from a regression standpoint, inversion is going to be more useful. When I do something like an arm bar and I'm doing rotations and things like that, that's going to be a progression because with the arm bar, if I'm doing things unilaterally, that means I'm driving certain things on one side and certain things on another. I'm rotating through the thorax. And when I do rotation, there's larger excursions that are needed to complete the task. For example, if I reach forward, there's a certain amount of movement that happens in the thorax when I do that, but then when I reach further on one side than the other, I have even more motion that's needed. So it's harder. So I would put arm bars later on in the swing of things before or after inversion-based activities. Just as I had talked about in previous debriefs, it's easier to do a bilateral move like a squat than it is to do a hip shift for the same reasons. So that's where I would go in terms of the hierarchy of exercise selection. Especially too with the arm bars that I'm advocating for, there's a lot more moving parts. So from a coaching standpoint, there's just more going on. So it's harder to coach. So I would just consider that, Dan. Thank you for a great question, man, and I hope you're doing well. The last question comes from Ali. Again, killing it with them. Ali and Isaac, like Jordan and Pippen with questions. Here's what Ali asks. How can an occlusal splint inhibit neck breathing? Or how do the way teeth touch affect the neck and diaphragm? This is a good question. So if I am biting on one side, say I bit on my left, the jaw is going to move a bit to the left so those teeth can contact. What again, folks, is the relationship of jaw movement one way to the head and the neck? If the jaw moves one way, the head and neck move the other way. So if I can only bite on my left, that means my head can only rotate right. Well, unless I cheat. Same thing with the other way. If I can only bite on the right, then my rotation to the left will be dynamite. That can impact where you can and cannot rotate. So this is especially concerning potentially if you have someone who has missing teeth, because that might change where they do and do not bite. Now, you can work on developing sensory awareness of contacting teeth in certain positions. Ali mentions an occlusal splint as a potential way of getting the neck to relax. Yeah, this can happen because essentially what a splint does is it takes you out of your current bite. And what an occlusal splint would be a splint that's put on the bottom teeth. Essentially, that changes the way the splint contacts with the top teeth, so that can free up temporomandibular joint range of motion and potentially alter neck positioning, tone, and tension. It can be useful in the short term because what's nice about splints is you can use them to reduce any potential neck influences to allow you to get into positions you might not get into normally. But if you have some structural issues at play, you have some teeth missing, or you have a high arched palate, and let's say that's affecting your movement capabilities, eventually you're probably going to have to address that. But also too, if we keep it real, but not to the extent where things go wrong, if we look at the research in terms of how do splints work in terms of moving stuff, or are these useful for improving things like temporomandibular dysfunction, neck pain, things like that? There's some research showing that it can influence tension throughout the body if you're using a splint versus not. There's not as much research showing that it can affect pain in a favorable manner. And it's costly. So what I had mentioned before, if you want to use things to improve your neck range of motion, it is better and likely more reliable to do so with exercise as much as you possibly can. And even if you have a crappy bite, the body is very adaptable and we can make up for a lot of the structural issues that we may have. And it's not a death sentence if you have malocclusion. So please take that into consideration. Moreover, what I think is more important is taking into consideration the upper airway amount of space that you have in order to breathe through your nose is way more important than there would be something of having a malocclusion. For example, sometimes dentists will put people into a particular occlusion that might not be perfect, but it does allow them larger airway space so then they can get more air in and out. That's going to be way more important than you being able to, put your jaw or contact your teeth in a certain way. So addressing upper airway dynamics is always, in my opinion, going to trump what teeth will contact or not. Some people don't even care about occlusion in the dental world if you got the airway in place. So emphasize that first and foremost. I'll also say from a practical standpoint, and again, the number of people who I've put into splints is low, a handful, less than 5. And the reason why that is one, when I tried, wasn't really effective. Maybe that's some issues on my part. But 2, I think if the number of people who actually need that, assuming that they've been coached really well and they're still not getting changes, I think the true number of that is really smaller than you think, which is why I've only done it with a handful of people. My mission is to make sure that you beautiful, sexy, outstanding people who are tuning in have mastery of the basics, and most of us don't. And I can even think of the people who I've put into splints and failed miserably with. Looking back and reflecting on them, they did not have mastery of the basics. I did not coach the stack as well as I do now back then. And I don't want you to make the same mistake, because you're going to suffer, but also the people you're working with are going to suffer, because they're going to spend money on stuff that they likely don't need to spend money on. And really, they're probably not going to get as good a results because they can't put their body into the positions that they need to maximize the movement dynamics. So to summarize, splints do influence. When you contact teeth on one side, your head and neck are going to rotate to the opposite side. Do you need splints? Probably not too often. But, inability to contact teeth in certain positions can affect range of motion. What I think is more important is making sure you have full airway excursion, range of motion in order to make things happen. And do that. Do the stuff that we talked about earlier in this podcast, and you ought to be in business. Great question, Ali. I think that's a good stopping point for us today, especially because we got like a minute left. I want to thank you all for tuning in. If you want to learn more, go to zachcouples.com and subscribe to my newsletter while you're there. You'll get access to a bunch of free stuff. I offer a lot of services on that page. I want you to check that out. But I do want to mention, folks, that my seminar, if you want to learn how to really apply this stuff and get some hands-on coaching help, Human Matrix is the place to do it. I got a bunch happening this year, and because the world is kind of healing, we're going to make it happen. August 1st and 2nd, Boston, Massachusetts. September 12th and 13th, Montreal, Canada. October 3rd and 4th, Ann Arbor, Michigan. November 7th and 8th, Charlotte, North Carolina. November 21st and 22nd, San Diego, California. There's some happening in 2021. The reason why I'm hurrying is because I don't have much time left. So thank you for tuning in. You've been an amazing audience. I want you to keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.